What are the key differences between the treatment approaches for hepatitis B and hepatitis C, and how do antiviral therapies address these differences? Answer: the treatment approaches for hepatitis B HBV and hepatitis C HCV differ significantly due to the nature of the viruses and their associated risks. Hepatitis B is a DNA virus, whereas hepatitis C is an RNA virus, which impacts treatment options and outcomes. Hepatitis B is typically managed with antiviral medications such as tenofovir or entecavir, which are nucleoside analogues that inhibit the replication of the virus. These therapies aim to suppress viral load but may not lead to a cure. Long-term antiviral therapy is often required to control the virus and prevent complications such as cirrhosis and hepatocellular carcinoma (HCC). Hepatitis C has more recent advancements with direct-acting antivirals, DARs such as sofosbuvir and ledipasvir. These DAs have revolutionized treatment, offering cure rates above 90% in most cases by targeting specific steps in the viral replication cycle. Unlike hepatitis B, where treatment is often long-term, hepatitis C can often be cured within 1–2 weeks of treatment. In both cases, monitoring liver function and viral load through regular testing is crucial in guiding therapy and determining the success of treatment. A 58-year-old patient presents with progressive abdominal distension, low albumin levels, and a history of chronic alcohol use. Upon examination, ascites is noted and the liver appears enlarged. What is the most likely cause of these symptoms, and what are the next steps in management? Answer: the patient's symptoms, including abdominal distension, low albumin levels, and a history of chronic alcohol use, suggest the possibility of cirrhosis with complications of ascites. Cirrhosis is the end stage of chronic liver disease, often caused by long-standing alcohol consumption. Ascites occurs due to portal hypertension, which leads to fluid accumulation in the peritoneal cavity and low serum albumin levels, which result from reduced synthesis by the damaged liver. The management steps for this patient should include confirming the diagnosis with imaging such as an ultrasound or CT scan to assess liver morphology and the presence of acidic fluid, paracentesis to assess the fluid for characteristics like protein content, which helps to determine the cause of ascites and to exclude infection, spontaneous bacterial peritonitis SBP, management of ascites, which includes dietary sodium restriction, diuretics, spironolactone and furosemide, and fluid removal via paracentesis if needed. Evaluation for liver transplantation if the patient has decompensated cirrhosis, with a child pug score and MELD score to assess the severity. Explain the role of fibroscan in assessing liver fibrosis and how it compares to a liver biopsy. Answer: fibroscan, also known as transient elastography, is a non-invasive imaging tool used to assess liver stiffness, which correlates with liver fibrosis. It is often used in clinical practice to monitor the progression of liver disease, particularly in chronic hepatitis B and C, and in other forms of liver damage such as non-alcoholic fatty liver disease (NAFL). Fibroscan measures the speed of a shear wave passing through the liver, which is directly related to the stiffness of the liver tissue. The stiffer the liver, the more advanced the fibrosis. Fibroscan is highly effective in determining the degree of liver fibrosis with less patient discomfort and fewer complications compared to liver biopsy. Liver biopsy is considered the gold standard for assessing liver fibrosis, but it carries risks such as bleeding, pain, and complications related to the invasive procedure. It provides a histopathological examination of liver tissue, offering detailed information about fibrosis and inflammation. Comparison: fibroscan is quicker, non-invasive, and has fewer complications. It is also more suitable for frequent monitoring in clinical practice. Liver biopsy, while offering more detailed information, is more invasive, costly, and associated with higher complication rates. Mr. Johnson, a 65-year-old patient with a history of chronic pancreatitis, presents with new onset of weight loss, fatigue, and dark urine. His labs reveal elevated liver enzymes and jaundice. What steps should be taken to investigate the cause of his symptoms, and what are the likely diagnoses to consider? Answer: Mr. Johnson's presentation, including weight loss, fatigue, dark urine, elevated liver enzymes, and jaundice, suggests possible pancreatic cancer or pancreatic insufficiency with an obstructive component such as a biliary obstruction or pancreatic pseudocyst. The next steps in management should include imaging studies, particularly CT scan or MRI, to assess the pancreas and bile ducts for signs of pancreatic cancer or structural complications from chronic pancreatitis such as pancreatic pseudocysts or pancreatic duct obstruction. Endoscopic ultrasound ears for direct visualization of the pancreas and potentially a biopsy if a mass is identified. Liver function tests and bilirubin levels should be monitored closely to assess the degree of liver impairment. Elevated liver enzymes could indicate cholestasis due to bile duct obstruction. Management should focus on stabilizing the patient and addressing the underlying cause, such as surgical resection if a tumor is identified, or drainage of any pseudocyst causing obstruction. Possible diagnoses include pancreatic cancer. The new onset of jaundice and weight loss could be indicative of pancreatic cancer, which obstructs the bile duct. Pancreatic insufficiency with associated biliary obstruction or pancreatic pseudocyst. Chronic pancreatitis complications such as pancreatic ductal stricture. A patient with a history of chronic pancreatitis presents with complaints of steatorrhea, abdominal bloating, and diarrhea. What is the likely cause of these symptoms and what treatment options should be considered? Answer: patient's symptoms of steatorrhea, fatty stools, abdominal bloating, and diarrhea suggestive of pancreatic insufficiency, a common complication of chronic pancreatitis. In chronic pancreatitis, the exocrine function of the pancreas is impaired, leading to insufficient secretion of digestive enzymes, particularly lipase, which is responsible for fat digestion. This leads to malabsorption of fats, resulting in steatorrhea. Treatment options include pancreatic enzyme replacement therapy with preparations that contain lipase amylase and protease to assist with digestion, dietary modifications such as a low-fat diet and possibly vitamin supplementation, particularly fat-soluble vitamins A, D, and K, due to the impaired absorption, managing pain associated with chronic pancreatitis, often through analgesics or, in some cases, surgical intervention. Drainage of pseudocysts or resection of damaged tissue. A pancreatic function test or fecal elastase test can help confirm the diagnosis of pancreatic insufficiency. What is the significance of hepatocellular carcinoma (HCC) screening in patients with cirrhosis, and what are the recommended diagnostic modalities for early detection? Answer: hepatocellular carcinoma (HCC) is the most common form of primary liver cancer, and it is strongly associated with cirrhosis, especially when caused by chronic viral hepatitis or alcoholic liver disease. HCC typically develops in the setting of chronic liver injury, which results in the formation of cirrhosis, a key risk factor for the development of liver cancer. Early detection of HCC significantly improves the chances of successful treatment, as the tumor can often be resected or treated with a liver transplant in early stages. Screening for HCC in patients with cirrhosis typically involves ultrasound of the liver every 6 months to monitor for any focal liver lesions, alpha-fetoprotein (ALP) blood test, though it is not highly specific or sensitive and should be used in conjunction with imaging. If any abnormal findings are detected on ultrasound or AFP, contrast-enhanced CT or MRI should be performed for further evaluation. Guidelines suggest HCC screening for all patients with cirrhosis, especially those with a history of hepatitis B, hepatitis C, or heavy alcohol use. In the context of pancreatic cancer, what are the typical presenting symptoms and how do they guide the diagnostic workup? Answer: the typical presenting symptoms of pancreatic cancer include jaundice, particularly in cancers located in the head of the pancreas, which may obstruct the bile duct. Abdominal pain, often in the upper abdomen, which may radiate to the back. Unexplained weight loss and anorexia. New onset diabetes, particularly in patients with no prior history of diabetes, as the tumor may affect insulin production. Steatorrhea, if the tumor obstructs the pancreatic duct and causes pancreatic insufficiency. Diagnostic workup should include CT scan or MRI for imaging and to assess the tumor size and spread. Endoscopic ultrasound AIRS, which can offer high-resolution imaging and the possibility for biopsy. CA19-9 blood test as a tumor marker, although it is not diagnostic on its own, as levels can be elevated in other conditions. How is pancreatic pseudocyst managed in a patient with chronic pancreatitis, and what are the risks associated with this condition? Answer: a pancreatic pseudocyst is a fluid collection that arises from the pancreas due to chronic inflammation, typically seen in patients with chronic pancreatitis. It is usually located near the pancreas and is surrounded by fibrous tissue, unlike a true cyst, which is lined by epithelium. Management typically includes observation. Small pseudocysts that are asymptomatic and not causing complications may be monitored with periodic imaging, ultrasound, or CT scan. Drainage. If the pseudocyst causes symptoms, pain, infection, or compression of nearby organs, or if it is large and persistent, percutaneous drainage or endoscopic drainage may be performed. Surgical drainage. In some cases, if endoscopic or percutaneous approaches are not effective, surgical drainage or cyst resection may be necessary. Risks include infection, rupture, and compression of nearby structures, e.g., the duodenum or bile duct. The pseudocyst may also recur after drainage, necessitating careful monitoring. What role does immunosuppressive therapy play in the management of liver transplantation, and what are the risks associated with long-term immunosuppression? Answer: immunosuppressive therapy is essential in preventing rejection of the transplanted liver, as the recipient's immune system may recognize the graft as foreign. Common immunosuppressive medications include calcineurin inhibitors, e.g. tacrolimus, steroids, and antimetabolites, e.g. mycophenolate mofetil. The main goals of immunosuppressive therapy are preventing acute rejection and maintaining the viability of the transplanted organ, lowering the dose of immunosuppression once the risk of acute rejection diminishes. However, long-term immunosuppressive therapy has significant risks: increased susceptibility to infections, particularly opportunistic infections, e.g. cytomegalovirus, fungal infections, increased risk of malignancies, especially lymphomas and skin cancers, due to suppressed immune surveillance, nephrotoxicity, particularly with calcineurin inhibitors, and osteoporosis due to prolonged steroid use. What are the current recommendations for hepatitis C treatment, and how have recent advancements changed the prognosis for patients? Answer: recent advancements in the treatment of hepatitis C have transformed the prognosis for patients. The development of direct-acting antivirals (DOS) has revolutionized management, providing high cure rates, 90%, with short treatment durations, 1–2 weeks. Current treatment recommendations involve sofosbuvir and ledipasvir combination therapy, or other DAA regimens like glecaprevir-pabrentasvir. The choice of treatment regimen depends on factors like genotype, cirrhosis status, and previous treatments. Patients with cirrhosis may need extended monitoring for the development of hepatocellular carcinoma (HCC) even after successful viral eradication. DAAs are well tolerated and have fewer side effects than older interferon-based therapies. Successful treatment not only eradicates the virus but also significantly reduces the risk of complications such as cirrhosis, liver failure, and HCC. What are the key differences in the pathophysiology and treatment strategies for Clostridium difficile infection (C. diff) and Helicobacter pylori infection in gastrointestinal disease? Answer: Clostridium difficile (C. diff) is a gram-positive bacterium that produces toxins leading to inflammation and diarrhea, particularly in patients who have been treated with antibiotics. It is commonly associated with healthcare settings and antibiotic use, and the primary treatment strategy includes oral vancomycin or fidaxomicin with supportive care for dehydration. Relapse can be common, and in severe cases, a fecal microbiota transplant (FMT) may be considered. Helicobacter pylori, on the other hand, is a gram-negative bacterium that can cause peptic ulcers, gastritis, and increase the risk for gastric cancer. It is treated using a combination of proton pump inhibitors, PPIs, and antibiotics, e.g. clarithromycin and amoxicillin or metronidazole, as part of a triple therapy regimen. The infection can be diagnosed using non-invasive methods like urea breath tests or stool antigen tests. Management focuses on eradicating the infection to prevent recurrence of ulcers and other complications. In terms of pathophysiology, C. diff colonizes the colon and produces toxins, ECDA-ED, leading to mucosal injury and inflammation. H. pylori infects the gastric mucosa and induces local immune responses that can lead to ulcers and gastric cancer. How do you manage dehydration in a pediatric patient suffering from acute gastroenteritis caused by rotavirus? What factors should be considered when selecting fluid therapy? Answer: the management of dehydration in pediatric patients with acute gastroenteritis caused by rotavirus primarily involves fluid rehydration therapy. Key factors to consider when selecting fluid therapy include the severity of dehydration, mild, moderate, or severe, the patient's age, and the presence of underlying conditions like malnutrition or chronic illnesses. For mild dehydration, oral rehydration solutions, oils containing electrolytes such as sodium and potassium, should be used to replenish lost fluids and electrolytes. For moderate to severe dehydration, intravenous fluids may be necessary. The goal is to rapidly restore circulating volume and prevent shock. IV fluids typically consist of isotonic solutions such as normal saline or Ringer's lactate. The World Health Organization, who provides guidelines for ORS use, emphasizing the use of oral fluids as the first line of therapy unless the child is unable to drink or has severe dehydration requiring IV fluids. The use of antiemetics and probiotics may also be considered as adjuncts, although they are not central to rehydration. Mr. Turner is a 65-year-old male presenting with severe nausea, vomiting, and diarrhea for the past 48 hours. He has a history of chronic kidney disease and is currently on ACE inhibitors. His lab results show a sodium level of 128 mecl, potassium of 4.2 mecl, and a HEV 7.30. What immediate interventions should be considered to address his electrolyte and acid-base disturbances? Answer: Mr. Turner is presenting with electrolyte disturbances likely caused by dehydration secondary to vomiting and diarrhea, along with the effects of ACE inhibitors which can impair renal function. His lab results indicate hyponatremia, sodium 128 meckel, and metabolic acidosis, pH of 7.30, both of which require urgent correction. Immediate interventions include fluid resuscitation. IV fluids such as normal saline 0.9% NaCl should be administered to address both dehydration and hyponatremia. The goal is to correct sodium levels gradually to avoid osmotic demyelination syndrome, typically with a rate of correction not exceeding 810 meckel per 24 hours. Electrolyte monitoring. Potassium levels should be monitored closely, although the current value of 4.2 meckel is within normal limits. If there are significant losses of potassium with continued vomiting and diarrhea, supplementation may be required. Acid-base correction. The metabolic acidosis, pH of 7.30, suggests a need for bicarbonate therapy, particularly if bicarbonate levels are low. The underlying cause of the acidosis should also be addressed, likely linked to the gastrointestinal losses of bicarbonate. Discontinuation of ACE inhibitors. Given the possibility of a C inhibitor-induced hypokalemia or renal impairment, it may be necessary to reassess his current medications. What is the role of stool tests in diagnosing parasitic infections like giardiasis and amoebiasis, and what specific findings are used to distinguish between the two? Answer: stool tests play a crucial role in diagnosing parasitic infections such as giardiasis and amoebiasis. The diagnostic approach often involves multiple stool samples collected over several days due to intermittent shedding of the parasites. Giardiasis diagnosis is typically made by identifying Giardia lamblia cysts or trophozoites in the stool using microscopy. An enzyme immunoassay (IA) or direct fluorescent antibody (DFA) test may also be used to detect Giardia antigens. The presence of foul-smelling, greasy stools with a history of exposure to contaminated water is suggestive of giardiasis. Amoebiasis. The diagnosis of amoebiasis is made by identifying Entamoeba histolytica cysts or trophozoites in the stool. However, because the organism can also be asymptomatic in some individuals, the presence of red blood cells in the stool, along with clinical signs of dysentery, e.g. abdominal cramping and bloody diarrhea, can indicate invasive disease. Serologic tests can also be helpful in diagnosing extraintestinal amoebiasis, e.g. liver abscesses. A key distinguishing features: giardiasis is typically associated with non-bloody diarrhea and greasy stools, while amoebiasis can lead to bloody diarrhea and can involve extraintestinal spread, particularly to the liver. What are the clinical features and diagnostic criteria for diagnosing viral gastroenteritis caused by norovirus in an adult patient? Answer: norovirus is the most common cause of viral gastroenteritis in adults, especially during outbreaks. It is highly contagious and typically presents with acute onset of vomiting and diarrhea, often non-bloody, abdominal cramps, nausea, and fever. Diagnostic criteria. The diagnosis is primarily clinical, with stool testing for norovirus antigen or PCR testing being confirmatory. The clinical history of sudden onset diarrhea and vomiting during outbreaks combined with laboratory tests is essential in making the diagnosis. Management. Management is largely supportive, with oral rehydration for mild cases and IV fluids for those with dehydration. Antiemetic medications may be used to control nausea. Guideline references. CDC guidelines on norovirus management. How does metabolic alkalosis occur in patients with prolonged vomiting, and what are the primary interventions to correct this condition? Answer: metabolic alkalosis in patients with prolonged vomiting occurs due to the loss of hydrochloric acid (HCl) from the stomach, leading to an increase in bicarbonate levels. This loss of acidic content from the stomach stimulates the kidneys to retain bicarbonate, resulting in alkalosis. Prolonged vomiting can also lead to hypokalemia, further exacerbating alkalosis due to potassium shifts that affect hydrogen ion secretion in the kidneys. Interventions: rehydration. IV fluids such as normal saline or Ringer's lactate should be administered to correct fluid and electrolyte imbalances. Potassium replacement. Potassium chloride may be required to correct hypokalemia, which often accompanies metabolic alkalosis. Addressing the underlying cause. The underlying cause of vomiting should be identified and treated, such as addressing gastric outlet obstruction or managing a metabolic disorder. Guideline references. ACG guidelines on management of vomiting and alkalosis. What are the potential consequences of untreated giardiasis in immunocompromised patients, and how should it be managed in such individuals? Answer: in immunocompromised patients, untreated giardiasis can lead to persistent diarrhea, malabsorption, weight loss, and electrolyte disturbances. In severe cases, it can contribute to dehydration and systemic complications, such as secondary infections. The parasite may also invade the small intestine, leading to chronic symptoms. Management: treatment typically involves metronidazole or tinidazole as the first-line agents, though longer courses or higher doses may be required in immunocompromised patients. In addition, rehydration therapy and electrolyte monitoring are essential. Guideline references: CDC guidelines for giardiasis in immunocompromised patients. What is the role of endoscopic retrograde cholangiopin creatography in the management of acute cholangitis, and what are the potential risks associated with the procedure? Answer: endoscopic retrograde cholangiopin creatography is a critical diagnostic and therapeutic tool for managing acute cholangitis, a potentially life-threatening infection of the biliary tract. RCP allows for the visualization of the biliary tree and the removal of obstructions such as gallstones or strictures causing biliary obstruction. The procedure can also involve the insertion of a stent to relieve obstruction and facilitate drainage of infected bile. Role in management: therapeutic. RCP is used to remove gallstones or drain an obstructed biliary system, which is essential in treating the infection. Diagnostic: it provides direct visualization of the biliary tree, which is valuable in diagnosing the underlying cause of cholangitis, such as biliary stricture or cancer. Risks: pancreatitis is a common complication of RCP, approximately 3–5% of cases. Biliary perforation, which can lead to peritonitis. Infection: RCP can treat infection. It can also introduce bacteria into the bloodstream during the procedure, increasing the risk of sepsis. A 45-year-old male patient presents with intermittent right upper quadrant pain, nausea, and jaundice. His lab results show elevated liver enzymes, total bilirubin of 3.5 mdl, and a history of heavy alcohol consumption. What is the likely diagnosis and what is the first-line treatment? Answer: the patient's symptoms: right upper quadrant pain, nausea, jaundice, elevated liver enzymes, and elevated bilirubin, combined with a history of heavy alcohol consumption, suggest alcoholic hepatitis. This condition is characterized by inflammation of the liver due to excessive alcohol intake, leading to liver cell injury, which impairs liver function. Likely diagnosis: alcoholic hepatitis is the most probable diagnosis, especially in the context of alcohol use and liver enzyme abnormalities. Differential diagnoses may include viral hepatitis or biliary obstruction, but the history of alcohol consumption is key in suggesting alcoholic hepatitis. First-line treatment: alcohol cessation. The most important treatment is immediate cessation of alcohol consumption to prevent further liver damage. Nutritional support. Many patients with alcoholic hepatitis are malnourished, so adequate nutrition, including thiamine and folic acid supplementation, is essential. Corticosteroids. For severe alcoholic hepatitis, corticosteroids such as prednisone may be used to reduce inflammation and improve short-term survival in patients with a Maddrey's discriminant function (MDF). Score 32. Management of complications. If the patient develops complications like ascites or encephalopathy, they should be managed accordingly, e.g. diuretics for ascites, lactulose for hepatic encephalopathy. Guideline references: AASLD, American Association for the Study of Liver Diseases, Guidelines for Alcoholic Liver Disease, NIC, Guidelines on the Management of Alcoholic Hepatitis. A patient with Crohn's disease presenting with fever, leukocytosis, and right lower quadrant pain. How would you differentiate between an intestinal obstruction and an abscess formation, and what is the most appropriate initial diagnostic test? Answer: in a patient with Crohn's disease, fever, leukocytosis, and right lower quadrant pain could indicate a complication such as intestinal obstruction or abscess formation. These two conditions present similarly but differ in underlying pathophysiology and management. Differentiation: intestinal obstruction. Crohn's disease can cause strictures and narrowing of the bowel, leading to obstruction. Symptoms typically include crampy abdominal pain, bloating, and vomiting, along with distension. Obstruction may present with signs of bowel obstruction such as inability to pass gas or stool. Abscess formation. Abscesses in Crohn's disease are often due to fistulae or perforation. They tend to present with localized pain, fever, and a palpable mass in the abdomen. The pain is typically more constant and may be associated with signs of peritonitis if the abscess ruptures. Initial diagnostic test: CT abdomen with contrast. This is the most appropriate initial diagnostic test to differentiate between an obstruction and an abscess. It provides detailed imaging of bowel loops and can identify signs of an obstruction, such as bowel dilation, or an abscess, which will appear as a fluid-filled collection with surrounding inflammation. An ultrasound could also help identify abscesses, especially in cases where CT is not readily available or contraindicated. Guideline references: ACG Guidelines for the Management of Crohn's Disease, ASG, Guidelines on Endoscopic Diagnosis in Crohn's Disease. What are the primary causes of upper gastrointestinal (GI) bleeding, and how do diagnostic tests aid in differentiating them? Answer: upper GI bleeding is commonly caused by peptic ulcers, caused by an imbalance between mucosal defense mechanisms and aggressive factors like acid. Diagnostic tests such as endoscopy are essential for direct visualization and ulcer confirmation. The Helicobacter pylori test, urea breath test, or biopsy may be used for identifying infection that contributes to ulcer formation. Esophageal varices, typically due to cirrhosis or portal hypertension, varices are diagnosed via endoscopy where the presence of engorged veins is visible. Angiography may be used for preoperative assessment in cases of active bleeding. Esophagitis, often a result of acid reflux esophagitis, can be diagnosed by endoscopy and biopsy to rule out infections or malignancy. The goal of these diagnostic tests is to determine the origin of the bleeding, esophageal, gastric, or duodenal, and to guide management, e.g., blood transfusions, pharmacotherapy, or endoscopic therapies like banding or sclerotherapy. How does the management of lower GI bleeding differ from upper GI bleeding, and what diagnostic tests are typically used for evaluation? Answer: low GI bleeding typically originates from the colon or rectum and is commonly caused by conditions such as diverticulosis, inflammation, or rupture of diverticular causes bleeding. Colonoscopy is the primary diagnostic tool for locating the source of bleeding. Colorectal cancer. This may present with a cold blood in the stool or active bleeding. Colonoscopy with biopsy is used for diagnosis and staging. Angiography. This is used in cases where endoscopic evaluation fails to identify the bleeding source or when there is ongoing active hemorrhage. Angiography can also be used for embolization in cases of refractory bleeding. Unlike upper GI bleeding, lower GI bleeding requires careful assessment of the colorectal system. Hemorrhoids, rectal ulcers, and inflammatory bowel disease are additional differential diagnoses which can be identified through colonoscopy. Mr. Thompson, a 58-year-old male with a history of cirrhosis, presents with hematemesis and melena. Upon examination, he shows signs of shock, including hypotension and tachycardia. What should the nursing team do to manage his condition, and which diagnostic tests are essential for confirming the diagnosis? Answer: in this scenario, Mr. Thompson is likely experiencing a variceal bleed due to his history of cirrhosis and portal hypertension. Immediate management should include fluid resuscitation, administer IV fluids and blood transfusions to stabilize his hemodynamics, vasoactive medications, administer medications such as octreotide to reduce portal hypertension and variceal bleeding, endoscopy. Urgent upper endoscopy should be performed to identify the source of the bleeding, likely esophageal varices. Endoscopic therapy such as variceal banding or sclerotherapy may be required to control the bleeding. Diagnostic tests should focus on determining the extent of the bleeding. Liver function, liver function tests, coagulation profile, and assessment of varices, transjugular intrahepatic portosystemic shunt tips may also be considered for refractory variceal bleeding in the longer term. What are the primary treatments for achalasia, and how do they address the underlying pathophysiology of the disorder? Answer: achalasia is a motility disorder of the esophagus characterized by the loss of peristalsis and failure of the lower esophageal sphincter to relax. The primary treatments aim to relieve the symptoms of dysphagia by improving LES relaxation and esophageal emptying. These treatments include botulinum toxin injection. This treatment temporarily paralyzes the LES, promoting relaxation and improving swallowing. It is particularly effective in patients with mild to moderate disease, pneumatic dilation. This involves the mechanical stretching of the LES using a balloon. It can provide longer-lasting relief, but carries risks of perforation. Surgical myotomy. This procedure involves cutting the muscle of the LES to allow for permanent relaxation. It is typically reserved for patients who do not respond to non-invasive therapies. The underlying pathophysiology involves a loss of ganglion cells in the myenteric plexus of the esophagus, which prevents normal relaxation of the LES. These therapies help overcome the obstruction and improve esophageal motility. What is the role of prokinetic agents in the management of gastroparesis, and which pharmacological options are considered first line? Answer: Gastroparesis is a disorder characterized by delayed gastric emptying, often seen in diabetic patients or those with a history of upper abdominal surgery. The role of prokinetic agents is to enhance gastric motility and improve the symptoms of nausea, early satiety, and vomiting. The primary pharmacological options include metoclopramide, a first-line prokinetic agent that enhances gastric emptying by increasing the tone of the lower esophageal sphincter and stimulating gastric motility. However, long-term use can lead to side effects such as tardive dyskinesia, so it is often used with caution. Erythromycin, an antibiotic that has prokinetic effects by stimulating motilin receptors in the gastrointestinal tract. It is also used as a short-term option to improve gastric emptying. In addition to pharmacological treatment, dietary modifications such as smaller, more frequent meals and reduced fat intake are often recommended to reduce symptoms. What diagnostic tests are used in the evaluation of chronic constipation, and how do they help differentiate between functional and organic causes? Answer: Chronic constipation can be due to functional causes such as irritable bowel syndrome, IBS, or slow transit constipation, or organic causes such as colorectal cancer or metabolic disorders. Diagnostic tests used to evaluate chronic constipation include colonoscopy. This is used to rule out organic causes such as colorectal cancer or strictures. It is typically recommended for patients with alarm symptoms like unexplained weight loss or blood in the stool. Anorectal manometry. This test assesses the function of the anal sphincter and rectal sensations, which can help differentiate functional causes like anorectal dysfunction from organic causes. Barium enema or CT colonography. These imaging studies are used when endoscopy is contraindicated or when further assessment of the colon is needed. In cases where no organic pathology is identified, biofeedback therapy and dietary changes increase in fiber are commonly used to manage functional constipation. MS Roberts, a 45-year-old female with a history of diabetes, presents with nausea, bloating, and early satiety for the past few months. After an evaluation, her physician suspects gastroparesis. What dietary recommendations and pharmacological treatments should be provided to MS Roberts to manage her condition? Answer: In managing gastroparesis in MS Roberts, the following measures should be considered. Dietary recommendations: MS Roberts should follow a low-fat, low-fiber diet with smaller, more frequent meals to minimize gastric loading. Liquid meals may be recommended to ease digestion. Pharmacological treatment. The first-line treatments include prokinetic agents such as metoclopramide or erythromycin to enhance gastric motility. However, long-term use of metoclopramide should be avoided due to the risk of tardive dyskinesia. Gastric electrical stimulation may also be considered if symptoms are refractory. Additionally, managing her blood glucose levels is crucial as poorly controlled diabetes can exacerbate gastroparesis symptoms. How does the management of hemorrhagic shock differ between upper and lower gastrointestinal bleeding, and what are the key considerations for fluid resuscitation? Answer: Management of hemorrhagic shock and GI bleeding involves immediate resuscitation, but the approach varies based on the origin of the bleeding. Upper GI bleeding. Early resuscitation focuses on IV fluid administration such as normal saline or lactated Ringer solution, and blood transfusions to correct blood loss. Blood type and cross-match should be performed to ensure compatibility. Low GI bleeding. Resuscitation focuses on stabilizing the patient and identifying the source of bleeding. If the bleeding is massive, embolization procedures may be needed in addition to blood transfusions. Key considerations include monitoring hemoglobin and hematocrit levels, coagulation profiles, and hemodynamic parameters. Blood transfusions are guided by symptoms and the degree of shock rather than absolute hemoglobin values. What are the diagnostic criteria for colonic inertia, and what are the available management strategies for slow transit constipation? Answer: Colonic inertia is diagnosed by measuring colonic transit time, often through colonic scintigraphy or radiopaque marker studies. These tests measure the passage of markers through the colon and can help confirm delayed transit in the colon. Difficography. This imaging study is used to evaluate for structural issues such as pelvic floor dysfunction. Management strategies include laxatives. First-line treatment includes stimulant laxatives or osmotic agents, e.g. polyethylene glycol, to promote bowel movements. Biofeedback therapy. This is useful for patients with underlying pelvic floor dysfunction. Surgical intervention. In severe cases, colectomy may be considered if conservative measures fail to improve symptoms. What is the role of fiber in the management of chronic constipation, and how should it be incorporated into the treatment plan for different types of constipation? Answer: Fiber plays a crucial role in the management of chronic constipation by increasing stool bulk and promoting motility. It is categorized into soluble fiber found in oats. Psyllium absorbs water and softens stools, making it helpful for patients with slow transit constipation. Insoluble fiber found in whole grains. Vegetables adds bulk to stools, aiding in bowel movement for patients with pelvic floor dysfunction or IBS. The key is to start with gradual fiber introduction to avoid bloating or discomfort. For patients with slow transit constipation, osmotic laxatives may be used alongside fiber, while for functional constipation, biofeedback may be a useful adjunct.